Well, if you, in real world,
You gotta do what you gotta
if you
do.
don't find your lube and just get it wet with their saliva, I mean, I wouldn't spit on it, but
Well, like,
or get it wet. Or, yeah, I mean, you got to make it work, and you need it. So first, make sure you get all your equipment. You get this is the 4, and see how it's red. So what did I say about the size?
So there'd be one under their actual size.
So this would be
5
for patients 5 foot or greater. And it tells you on the size, you got 60 to 80 mLs. So with 60 to 80 mLs, you can inflate. I normally go in between, so like 70. But the problem is that most of them will go to the 60, to the minimum. So this one is 60. So you make sure your equipment is working. You hook it up. It's inflating. And it's working when this balloon here stays inflated. That's what this is for. Because remember, all this is going to be in the trachea, or in the esophagus, in their mouth. So you can see the balloons, but if this is open, if this is filled, everything else is filled. If this deflates, the air is leaking. So now that your equipment's working, you leave it hooked up. You open the airway. You literally open the airway. This is the one time when you actually stick your finger in there. You open that. You hold the tongue. You open the airway. Bring it up, and come sideways. Still not going. No, you shouldn't meet all this resistance, but there's no lube. They literally go in all the way. Again, it shouldn't be this difficult because there's no lube. So once you go in all the way, and you let go, you come in sideways again. Switch, you let go. You never let go of the tube until it's secured. Until you either tape it or get one of the endotracheal tubes. We don't have it there in the other room. But you never secure it or never let go until it's secure, safe. If you have tape, just get some tape and you wrap it around and come around, wrap it again, come around, and then you can let go. Again, make sure contraindications, gag reflex. If they don't have gag reflex, then you're good. So once you're in, once you're in, you inflate again, and because of the small balloon outside, and you let go. All this should be already, ready to go. You hook up the BBM there. You start bagging. As you start bagging, you start pulling out a little, few inches, until you get good rise and fall.
That way you know that the orifice is there, it's coming out in the rise.
Exactly. So now when you get good rise and fall, this is mannequins in there. Remember, this is loose, so it's not inflating all the way. But what's the best way to know if you're doing it right or not?
Chest rise.
Good chest rise and fall, and auscultate, pretty much. Remember, this is not a secure airway, so there's a possibility of air going into the belly still, even though it's reduced. There's a possibility. So I always still auscultate the belly, so that's what we call the epigastrium. Every time the patient's intubated or whatever, check the epigastrium first, right up here, the upper belly where the stomach is. Auscultate, you might hear air, that's normal. But just remember, keep in mind that, air is going to go in there, eventually it's going to come back out. With what? Vomit and acid or whatever they have in there. Huh?
What do you normally hear?
Just air. Every time you're back, you're going to hear. It might not be much. It might be completely absent, or it might be a lot like, but you'll hear it. But just make sure, I do that. Normally they do that with endotracheal tube. I do it with everything because once I know, if I hear, again, small tricks, you're not going to be tested on it, but small tricks little things that will make you a good ENT, and you go out there and you're working with your partner or some ENT student or whatever, and you auscultate that. And then your medic, let's say they don't do that. And I've never seen anybody do it. I just do it, and they ask, "Why are you doing that? You're not breathing in the belly. There's oxygen, there's air movement in there. So, well, it's only a matter of time. If there's too much pressure, it's only a matter of time before they throw up, because all that stuff is going to come back up. The greater the pressure, the faster it's building up, the faster it's going to come out. Simple. So, anyways, you moved out, you pull it back a little until you got good chest rise and fall. Then now you secure it. Now you come and you're holding it, and somebody comes, either you or somebody comes with tape, and wraps it around with tape. You can swing it around a few times, come around, swing it again, come around, and now that it's secure, it's in the mouth. You don't have to hold it. Always recheck, and you wanna mark where you had it in the teeth. See the 16 centimeters here, right here. See the teeth, 16 centimeters. You wanna mark it, and I would write on the tape or whatever, or on your glove or whatever. 16 centimeters. You know. The measurement, because now you know for the next time, let's say 5 minutes later when you're reassessing, the tube is like out here and you see 16 centimeters, oh crap, you know, now it's almost 14, that means the tube came out a little, you got to reassess. I still got good chest rise and fall, okay, if it came out too much and there's no chest rise and fall, then you know that you're out, you got to take it out, or deflate it and you know, try it again or whatever, but that's pretty much how it works. Any questions? And we're gonna have plenty of time.
I thought a certain amount of air is supposed to go in that balloon, right? Or is it the whole syringe of air?
It's every tube
60.
60 to 80. Every good job. Every tube has a different setting. This is 60 to 80. I think this is 70 to 90. I thought there was another purple one around. Yeah, this is 70 to 90. This is 60 to 80. The smaller one, I believe, is
Is that for a taller person?
45 to 60. Yeah. Remember the numbers. Remember, this is a 4, which is for what type of patients? High? 5 foot or above. This is number 5, and it's purple, so it's for 6. So exactly. So remember, it's going to be
That's the normal one.
Yeah, this is the average one that we use. I never use a purple one.
So the pediatric
have to
or
be it?
The
children,
pediatric is yellow. It's in the other
yellow.
room.
So it's
if
gonna
we
be
switch,
45 to 60.
45 to 60, correct. So, and then that's it with the king. And then there's other ones. They're smaller. There's green ones, but we don't carry an orange cat. We just started carrying them.
Do you have
for
any
like-
name for king tubes?
Huh?
How do they have another name? King tubes besides king tube?
No, just king tube.
Just king tube?
Like king LTSD or whatever that is. Like endotracheal.
Endotracheal. That's okay.
Sub.
So they use that in
whatever.
universal language.
Yeah, but king. Yeah, that's it.
Okay. In ER, they use the metal piece to open instead of holding it. You know, they have the metal
blade.
piece, the blade.
Yeah, but you're talking there. That's intubation.
Intubation, yeah.
That's not this.
Ah, okay.
This is remember. This is what I said. This is the closest thing you got to intubation as EMTs. This is it.
Yeah.
Intubation is an ALS skill because you actually need to go inside the trachea, and that takes practice and.
That can be quite hard to get a good grasp on.
Oh yeah, dude. Yeah, I missed 2 before I actually got 1. You know, and it's practice. And again, it also depends on your patient. You get the 500-pound guy, you know, which is all fat and all that. It's gonna be way harder than your 140-pound guy, and you don't even have to lift a lot. You just see it. That's it. Somebody with anaphylaxis or severe airway or allergic reaction with a swollen tongue, swollen airway, might be impossible to do it. So, but that's basically how the king tube works. Any questions? No, good. All right, you can go and.